Hi, everyone, and welcome to another exciting episode of What's Up, Doc. Today, we have a special guest, Dr. Sean Skillern, a vascular surgeon from Ventura, California. Dr. Skillern is here to answer your questions in real time about how our blood vessels work and how to keep them healthy. So get ready to learn some cool stuff about your body and ask any questions that you might have. But let's give a big welcome to Dr. Sean Skillern. Thank you so much for joining us, Dr. Skillern.
Yeah, very much looking forward to it.
Thank you so much. So, as we get started and we're allowing the questions to come in, I love for everyone to hear, why are you so passionate about saving legs?
I would say of all the things I do, the work with the PAD may actually provide the biggest benefit to the patient, at least in their mind. So there's some operations that we do like aortic aneurysms or carotid disease, and we do it for prevention of things like rupture or the risk of death or the risk of stroke. But the patient doesn't necessarily note a difference other than maybe having less anxiety about that event occurring. It doesn't necessarily improve their quality of life. But people who have bad PAD or even moderate PAD, they're often their lifestyle is often limited from it.
Yeah.
And I would say between that and the patients with varicose veins, when you are able to improve them, first of all, you're able to improve them right away. It's not like it takes 10 days for it to happen. It happens later that night. And they're just very appreciative. I think that's one of the reasons why I like it the most.
Interesting you bring up varicose veins. A lot of our patients talk about that as well. What are the indications for treating varicose veins, and what are some of the latest treatment options that are available?
Well, indications. So again, remember, we're kind of in a specialized area. So some indications would be if people have advanced changes from their varicose veins. That's relatively unusual. Things like ulcers or severe thickening of the skin. Most likely, people will just either they just won't like them or they are uncomfortable or they're symptomatic. And if you don't like them, you don't have to have them treated. If you want to have them treated, that it can be done because the techniques today are pretty safe, non-invasive. Typically, it can be done here in the office in 30 or 45 minutes.
Are there any cons to actually uh, getting your varicose veins treated if it's just for a cosmetic reason?
So if you if you talk about the let's just say if you have the standard varicose veins, like almost like the wormy like veins on the legs, that's almost always coming from leaky valves within one of the larger veins in the legs. So normally
Interesting.
we need to close that vein down. And we could close it down with either a glue-like substance or with different types of heat energy. So in general, I tell patients that I mean nothing in life is free, but the risks are pretty low. So there's a less than 1 in 100, less than 1 in 200 chance of getting a blood clot after the procedure. So we check everybody after the procedure to make sure they don't get one. And then with some types of treatment, there are nerves which run next to the veins, and you can get a thermal injury or like a heat injury to the vein or to the nerve. That often is reversible, but it's very nice to know ahead of time.
We are going to get to some of our questions here. I get twitching and throbbing in my legs that can be visibly seen. Is this part of PAD, or have I got something else going on as well that may need investigating?
To me, it sounds like they are describing when your muscle fasciculates, when it kind of goes into little spasms.
Hmm.
And that by and of itself, I don't think is a big deal. Sometimes you might be able to see it with some abnormalities within your minerals or your electrolytes. Usually, that would not be a manifestation of peripheral arterial disease. So I don't know if I would bring it up with the primary care physician unless they said that it's actually bothering me because they had mentioned throbbing. So if it's throbbing, that might be uncomfortable, and it probably would be worthwhile to just take a
We have Heinz that has a question for you. He is here. He is going to ask your question personally. Go ahead, Heinz, and then we'll get to Alan.
Hey, doctor, thanks for joining this evening. Like many of us PAD patients, when we first got it, we were put on medications like atorvastatin and Eliquis and whatever else. I was put on mine like almost 5 years ago, the statins, and then eventually aspirin and everything else, and Eliquis, Plavix. But I got treatments already a few times, be it stents or atherectomy and ballooning in my thigh, SFA, but it keeps getting reoccluded. So why should I continue to take statins? My cholesterol was never high.
Well, first of all, you have a fantastic background behind you. Where is that?
That's actually Glacier National Park.
Yeah, that is beautiful.
Thank you.
So that's kind of a complex question in terms of whether you should take the statin or not. I would strongly recommend it. So what you've demonstrated is that you have significant peripheral arterial disease, that even after treatment, the blood vessel reoccludes or closes back down again. So the role for statins in people with peripheral arterial disease is primarily to help reduce the risk of plaque progression. But when you look at peripheral arterial disease is really a part of generalized atherosclerosis, which is plaque formation throughout your body. So, if you have an SFA that is occluded, it would not surprise me if you are at risk for coronary artery disease and in other vascular beds like the carotids.
Alan, go ahead and unmute and let's ask Dr. Skillern your question.
Hi, doctor. Thank you for being here. I really appreciate it.
Yeah,
Um,
absolutely.
I just got diagnosed with PAD in February and with peripheral arterial um, disease just about a month ago. And last year, I had some days where I'd be out for a walk and I would notice a warming sensation just above my ankle on my right ankle. And this year, I didn't really notice it for a long time, months and months and months. And then this year in September, it came back and it was there for 7 to 10 days where I would feel it, usually when I'm going for a walk, sometimes just, standing around at home. But I haven't felt it since mid-September. No sensation at all. So is that something that I shouldn't be too concerned about unless it comes back, or should I ask a doctor to check me out?
So again, I'm kind of the mindset, does it bother you? So when you're describing it to me, it doesn't really sound like a manifestation of peripheral arterial disease. So
Okay.
typically when people have symptoms, it's very reproducible when you're walking. So I have patients that will tell me, I'm walking and it's the same darn house. Every time I pass it, that's when I feel the cramping or the pain in my legs. A heat-like feeling, that sounds a little bit more nerve related. So I don't think that has anything to do with your peripheral arterial disease at all.
Okay. Okay. Thank you.
You're
Thank
welcome.
Fantastic. Okay, we have another question coming in online. How many times can stents be cleared to open them up? And if I do decide on a bypass, what is the contingency plan when that bypass fails?
So
That's a
this
loaded question.
well, is this person online right now?
No.
Okay. All right. So this person has had a lot of intervention. And I think the short answer is it depends if when you would consider bypass. First of all, what are the indications? Is it just because they're having pain? Is it because they have an ulcer that's not healing, or maybe even gangrene or the toe turning black? So it really, part of it depends on the indication. If the toe is black, then it would depend on what is the success rate of the minimally invasive treatment or the quote stent clearing. And in general, if you do something and that doesn't last, And I think at that point, you would pretty strongly consider going to a bypass if it's indicated.
It's interesting that we do, if someone's feeling that calf pain, they know that they have a blockage in there. It's really easy for someone to say, I don't understand why my doctor won't treat me. And there are doctors that will treat them, even though the indications are that unless you are experiencing lifestyle limiting claudication, or especially the rest pain, or you have a wound that won't heal, that's when you treat. They'll want treatment sooner. And so I really would love for you to explain to those listening why you don't always need to treat, even if a stent does get blocked up, or even if you do have a general blockage and you've never been treated.
So that's actually a question that we all encounter just about almost every day in our practice. And that is, when do you actually intervene? And for people who come in, let's say with their first diagnosis for peripheral disease, let's say they get some discomfort when they walk. Most people have not optimized their risk factors, which is pretty important before you consider intervention, right? If someone's foot or leg is about to fall off, then you don't have time for that. You go straight to improving the blood flow as fast as you can. But if someone has some discomfort walking, then it's often multifactorial, all of the different factors that end up leading to where they are at that point in time. So at that point, you kind of sit down and you go, okay, have we optimized our blood pressure? Have we optimized management of diabetes or blood sugar? Have we actually started an exercise walking program? And you don't just say, hey, just go walk. You need to, I actually tell my patients very specifically how I want them to do it, because it actually makes a difference. And it's surprising how many patients will come back after 3 months and they thought things were really, really bad. And they're like, you know what? I'm doing better. And you're like, great. Let's keep an eye on it with an ultrasound in a year.
So how do you explain to your patients they need to walk? How do you walk effectively to grow those natural bypasses?
So I like, again, a part of it depends on where the patient is. So some patients are very deconditioned. Some patients may have some balance issues. So first of all, we may try to just to optimize the walking. So number one, I want to get them walking. I want to get them to understand that they need to be out at least 5 or 6 times a week. And then I want them to build up to 45 minutes to an hour. A lot of our patients are retired. If they don't have to work, then they have a chance to go for a walk in the morning. They can do 20 or 25 minutes in the morning, and they can do another 25 minutes in the evening. They can split it up, but it's just a matter of getting out there and doing it.
And we always tell patients that they need to walk through the pain. If it's not hurting, you're not doing anything. You got to get out there and try and trigger that claudication sooner rather than later. We tell them they need to walk at a pace that triggers that claudication sooner rather than later. And the claudication is a really good sign that the pain is telling the body, hey, we need to grow these natural bypasses, and we need to teach the muscle to learn how to work more efficiently and effectively with less blood flow as well. So push through that pain to the point that you're limping or you're going to cry.
So,
and then do it again.
So I do think you're pretty close to spot on right there. I actually tell my patients something very similar. So I want you to walk until you get the pain, and then I want you to keep walking. I want you to keep walking, and then until you start getting really mad at me. And then at that point, you probably can stop and rest, and then keep going.
Love that. I always say, when you're cursing my name, you're doing a good thing. It's working for you.
Exactly.
We have a question that's coming in from YouTube. What's Up Solar is the code name. Says 1 year past 3 surgeries, 1 angiogram for reduced flow. That was a failure. Then a bypass that occluded after 2 weeks. Follow-up angioplasty 2 months later. That was also a failure. So this goes, along with what you were saying a few moments ago, I think, is, have you mitigated your risk factors? Have you stopped smoking? Are you eating right? Do you have a certain clotting disorder that you need medication for? that all plays along with it. When you see someone like this that is constantly reoccluding that quickly, what comes to mind?
Honestly, a smoker who has kidney failure. Those are probably the toughest patients with peripheral arterial disease. But yeah, you have to, especially if they have a very good, if they have their own vein that you can use to bypass, and that doesn't work, then you really have to start thinking about, are there other things going on in the body that is precipitating these failures?
Yeah, we have quite a few people who do still smoke, and the doctors will tell them, hey, we're not going to treat if you continue to smoke. Now, that's more for people who have intermittent claudication or possibly some lifestyle limiting claudication. If you have a wound that is not healing, of course, they're going to treat. That's going to come with a disclaimer that I'm going to tell you it's not going to last. Would you mind explaining why these procedures do not last when you continue to smoke?
I'm not sure I know the exact reason why, but we know that whether all interventions or even without intervention, the natural history of their disease will worsen if they continue to smoke. And we know that if they stop smoking, that they get almost immediate benefit. Not as if they go back to being a non-smoker, but their benefit is way more than you would expect, even for someone that smoked for 30 years, 2 packs a day. They could really realize significant benefit to their bodies, their lungs, and their blood vessels.
We have another question that's online here. I've been experiencing leg aches, tightness in both legs since the beginning of October of this year. Veins in both feet are the size of worms and hurt a little on and off. I'm 49 years old. Am I too young to have PAD?
I'm sorry, how old is the person?
49.
No, not too young. I would say less likely to be PAD, more likely to be symptomatic from her varicose vein disease. I would have her get a good venous reflux study, which is the type of ultrasound that I like to get on patients if I'm evaluating for disease or varicose vein disease.
That's good advice. How about Marcia? Marcia, go ahead and unmute and ask Dr. Skillern your question.
Sorry. Sorry about that. Yeah. Yes. Hi. Thank you, doctor, for being here.
Yeah, absolutely.
My question is I have a full metal jacket, SFA, and it's occluded. And so I walk like crazy, and I do pretty well, generally speaking. My question is, in the beginning, when my legs would ache and my thighs when I slept, just ache, and it's almost like I can feel my arteries, and it pretty much went away the more active I got. But it woke me up at about 5 o'clock in the morning doing it again, and I'm wondering, like, what is that?
It's not from your peripheral arterial disease.
It's not?
No. So the symptoms that you get from peripheral arterial disease, unless it is critical, you're not going to experience it when you're resting or when you're sleeping or even if you're just standing. So it's much more likely to be something else. Maybe coming from your back, maybe.
Okay.
I would guess back.
Okay. Thank you, because it was worrisome that it would wake me up, from a sound sleep.
No, not in your thighs. Not going to be peripheral arterial disease. So keep walking.
Even if that's where the blockage is, though?
Correct. Yeah, we almost always feel the symptoms in the major muscle groups below where the blockage is.
All right. Well, I felt that.
Yeah, I bet you did.
Okay. Yeah. Okay. Thank you.
You're welcome.
You'd be so proud of Marcia. Marcia is one of those, and she ends up with, block stents, and she goes out there and she's stopped the revolving door, and she is out there pushing herself every single day, pushing through that claudication and just walking. And she's been able to delay any other procedure since. So we're so proud of her. She's doing great, kind of our poster child of walking as medicine.
Thank you.
Okay, we have a question coming in over here from Marie. It doesn't look like she wants to actually ask it herself. How do we build collaterals in our arms? We have actually, I know it's rare to get PAD in your arms, but we have several people in our network that actually do have it. She is one of them. And she wonders if you can actually build collateral vessels in your arms for those that have PAD in all of the limbs.
Well, I would this question has never come up, and so I see a lot of patients that have peripheral arterial disease that affect the blood vessels in their arms, but I'm not sure I've ever come across someone that's symptomatic. So you may notice that the blood pressure is lower than one arm or the other, but unless that patient has kidney failure and has a shunt or a circuit in their arm, it's unlikely to cause significant blood flow problems to the hands. So naturally, we all have actually a lot of collaterals to begin with in the upper extremities. So I don't think you would need to do it. I see someone that said had emergency surgery for it already. That is probably from a more likely from a blood clot, not necessarily from arterial disease.
So something more acute, hypercoagulability that may mimic PAD. That's typically what you see, because we've had a couple of people that have ended up with gangrenous fingers, and we've had one that was amputated, had her fingers amputated. They said it was likely the clot that got there.
Yeah, so it could have been a clot. I mean,
clot.
they definitely need to be under the care of a vascular surgeon at that point, because you need to start thinking about other rarer etiologies.
Hmm. So we have Sue that is commenting on YouTube. A PAD patient, doctor told her to walk, but when she walks with pain, the bottom of her feet become very pale and sometimes the toes go gray. When should they worry and seek care?
No pain?
Yes, it's with pain. When I walk with the pain, so when I'm walking with claudication and pushing through the pain, the bottom of her feet become pale and sometimes go gray.
So I'd probably want to know, where is her claudication? Is it actually in her calf muscles? I would want to get some her arterial ultrasound, and as well as also like to measure the pressure in her toes. It doesn't necessarily bother me what the color is doing when she's walking per se, as long as it's returning. But if it's like that at rest, that can often be a sign that things are getting kind of near the critical level.
So that is something that if you are listening still, Sue, if you can put into answer his questions in comments, we're happy to have Joshua, our YouTube producer, actually bring it to us and we can readdress that and bring that to the doctor's attention as well. Okay, we have Carol. Carol, do you want to go ahead and unmute and ask your question? That's a long question. Where are you? There you are. Go ahead and unmute. Let's see if we can get her to unmute here. I'm not sure if she can unmute. Okay. I'm going to go ahead and read this. I don't know if you can see it, doctor. How do you feel about, yes, advice to consider bypass as femoral stents keep blocking? There's always a risk going in every single year, and bypass would give you years. I'm only 66 years old when walking 30 minutes or a treadmill 5 days a week and have no wounds. I think that this one, I'd love to just answer that. I mean, if you're not experienced, if you can walk 30 minutes, we have patients that can't even walk 30 seconds. But if you can walk 30 minutes, that is the best medicine that you can actually have. And you're going to stop or delay that revolving door of treatments. Like, why expose yourself to a big open procedure when you can actually walk and it's not limiting your lifestyle? Am I on track, doctor?
Totally agree.
Did we answer your question? You can nod, Carol. Yes. Okay, great. Okay. I'm just trying to juggle here. I think this is back with Sue. Sue is commenting on YouTube here. After resting for a little bit, the color comes back in her feet. The color of the toes come back after resting just a few minutes, but she's still not telling us where the pain is, if it's in the calf or it's actually in the foot, that she's experiencing it. So hopefully she'll get back to us there on that.
Or the toes.
Or the toes.
Yeah, I'd want to know if she's having pain in the toes.
Okay, so hopefully he'll get that for us. Our next question is an interesting one. We have a lot of folks over in Europe that want to know your opinion on a few things with the NHS. So you can let us know and carefully answer the questions. I know they're always politics, but our healthcare in the NHS is at no cost, but it's an 8-month wait to see a vascular surgeon in South Yorkshire of England. Is this acceptable? How would you, as a surgeon, feel if patients in the US could not see you soonest?
Well, that's a loaded question.
I know.
Let's see if I can navigate this without getting in trouble. So let's just say if it was one of my family members, I don't think I would consider it very acceptable. So, but again, we don't live in socialized medicine, so I would hope that in a situation that requires more urgent treatment, that person would be able to get it. So if their symptoms were truly disabling, or if they were in danger of tissue loss. And again, I don't know how well their preventive care is. So perhaps, while they're waiting 8 months to see that vascular specialist, maybe their primary care physician can have them on an exercise walking program, decide if they need a statin, optimize, their other. So that's a tough one, but yeah, that's a long wait.
Yeah, we have a lot of patients that are over there in some parts of England right now, smaller communities especially, where they do have these long waits. And even if they do have the wound that won't heal, the doctor says if you can't wait or you see it degrading, just go to the ED. And so they handle it that way, and that's how they were able to expedite care, which is a little frustrating for patients. And I know with EDs, they're already overbooked, especially if we're going into the winter season, the cold and flu season. They're definitely overwhelmed. And so it just adds one more thing. And it's a little frustrating. Patients are always looking for help in navigating their care. So okay, we have I'm not sure, Joshua, our YouTube producer has Rob that's here, dealing with CKD, and you had mentioned that's a serious issue with chronic kidney disease, especially in the later stages, ESRD, and stage renal. Left one, I think he's talking about his kidney is dead, and the right one is carrying everything. And after full graft replacement, 7 years later, now being told nearly a complete stenosis or occlusion of the native infrarenal aorta and bilateral iliac arteries, wondering what the life expectancy is for a second surgery of a full aortic graft replacement from the heart to each leg and everything in between. Now, I have a feeling, so, is he talking about the axillary, which is rarely
No,
done?
I think he's talking at this point. He's probably talking about an aortobifemoral bypass.
Aortobifemoral. Okay, making sure.
And so the short answer is that it's one of the best operations that we have, and we've got lots of data for probably 70 years, and the number of grafts that are open at 10 years, anywhere from 80 to 95%. So there's a good chance it'll last him the rest of his life if that's what he needs.
I have two patients that one has an aortobifemoral bypass 25 years, and the other one is 31 years. Can you
Yeah.
believe that?
It's
It's
a great.
absolutely incredible. The only thing is that it's a rough recovery. It's a rough procedure. It's a pretty big procedure. Once you get beyond that, if you know it's just going to be a rough road, there is a light. Um, how do you choose a doctor for a big procedure like that? Because, operator does matter. So are there any critical questions that you could ask before a big bypass such as that to ensure that you are getting someone who is using the most advanced techniques available for these bypasses?
So I think the thing that would probably be most important would be their experience. So 20 years ago, 30 years ago, everything that we did was open bypasses. And I've been out in practice for 22 years. So I kind of bridged that training area where we really started learning how to do the minimally invasive procedures when I was in training. But now I would want to know, what is their experience level? Because a lot of people have tons of experience with the minimally invasive options. But one, if you have to consider doing actual bypass, either from the abdominal aorta or the lower extremities, you probably just ask them, how many of these have you done? And if the answer is zero, then you might want to ask them if they would suggest anyone else.
It's interesting. We had a patient, we had a doctor that we interviewed in the past few months that someone came to me and said, I don't like that doctor. He did his very first bypass on me and it failed. And it was horrible. And I've been suffering since. And I said, why would you let someone who's never done before? I know they have to practice on someone, but why does it have to be you? I mean, seriously.
Yeah, I mean, when we get out in practice for the first time, we all have to do our first one. Hopefully, you're in a place where you did your training where you have a lot of experience. And that's probably the best advice I could give. That's one of the advices that we look for when we're looking for new surgeons.
Yep. Okay. So we have another question that coming in. This is interesting because we get it all the time. The phrasing of this may not relate to you, but the main concept of this question is just there. A lot of people think that taking calcium orally it can actually lead to plaque buildup in the arteries or calcium in the arteries. So Carol says, wondering if studies have shown positive correlation between calcium supplementation and PAD. And if so, what is recommended for, let's say, osteoporosis if diet is optimal and doctors insist that you must take calcium?
So I am not aware of any studies that have ever showed a link between calcium supplementation and calcification in the vessels. Certainly for peripheral arterial disease, is it possible it's ever been shown in the cardiology literature? It's possible, but I would really doubt it. And what we do know for sure is that osteoporosis untreated can have significant effects, fall risk, and really a lot of morbidity to the patient. So I would there are lots of great treatments for osteoporosis. I would not hesitate to do what is recommended.
Okay. We have another question here. This one's interesting. I have factor V Leiden and stopped my warfarin as they couldn't get my INR levels right. I would be called in the middle of the night telling me that I had to get to the hospital as a matter of emergency as my INR levels were above 10, which they should be 2.5. This just does not suit my lifestyle as I work nights. Are there other medication options other than warfarin or Coumadin for factor V Leiden?
I would definitely be on one of the newer classes of drugs, the either Eliquis or Xarelto. I think that they are used. I have very few patients who are still on warfarin.
That's interesting. So it is, and obviously, if you're using it for your patients with factor V Leiden, that you're finding success with it.
Yeah, and I'm pretty sure that even my hematology colleagues that may initially see the patient and make the diagnosis of factor V Leiden being positive, that they are using these other class of drugs because for that exact same reason is you just cannot regulate the levels very well. So you might want to, I don't know if you might want to spell out the Eliquis and Xarelto, Eliquis, and the Xarelto is Xarelto.
Perfect.
And you may want to just ask your doctor about both of them, just because some insurances will have a preference on which you use.
It's amazing. Do you ever feel with the insurance companies, are you a doctor? I'm the one with the patient. And we're seeing it more and more with PAD today, where you as the doctor are being second guessed by an algorithm. And that must be frustrating for you.
That is very frustrating.
Okay, so we have another question coming in here. What is your experience with Repatha versus other statins? I started it October 1st, labs drawn July 19th and November 18th. Cholesterol was 165, now at 64. LDL 109 to 13. I'm happy with the results, Cindy.
That is quite impressive. I'm actually a little bit jealous. I don't know if I want my LDL quite at 13, but less than 40, I would love it. So we have lots of experience with Repatha. I think it's a great.
Okay. And Tracy has a question about her husband. 6 weeks post-op for a fempop bypass, still struggling with his leg. It's swollen, hard, and uncomfortable. Is this normal? Swelling is mainly below the knee, and they checked for clots, and there are none. So what else should she be looking for or asking her doctor about, or his doctor?
So I would want to know when they check the ultrasound to make sure there's no blood clots. The swelling is still very normal. Sometimes it's just because of the incision, and it could take up to 6 months for the swelling to get better. But if it's significant swelling with a lot of firmness, I might even ask the doctor to reconsider doing another ultrasound. And then if that's also normal, then probably wear compression stocking. And that should help.
It's interesting. We've had a couple of bypasses where that were done, and the doctor did find a great landing zone in one of the vessels, but the other two tibials, the other two vessels below the knee, uh, were all blocked up. So there was basically one vessel run off into the foot, and the bypass just quickly went down. I don't know if you've seen that, before, and then they end up having to go to a different doctor, and then having the additional vessels opened up, or at least one other vessel opened up to make sure that there is sufficient flow below the knee to support the faucet being turned on.
At least in my experience, that's not necessarily going to be the case. So if the blood vessels to the foot are good and the blood vessels in the foot are good, then one vessel runoff is just fine. It's when when the blood vessels downstream are very, very diseased, and then it doesn't matter if you have three vessel runoff, it may not stay open. But
As long as you got that one.
in those situations, I do like to use anticoagulation.
Yeah. Okay, we have another question. Why would my leg swell up after walking, especially around the thigh? What are the clear signs of a blood clot? And are symptoms different for vein blood clots versus when you have one in your artery? And why do you develop a clot acutely in an artery versus in the vein?
Okay, so that's like six major questions that you could probably take an hour on each one. So
Yes.
let's go because they are all completely different arteries and veins. But I would say let's just go to the question about why would one leg swell up after walking. So there could be issues with the lymphatics, which is kind of all the fluid in your leg and your other parts of your body that's not a part of your blood vessels. Or it could be from significant venous insufficiency just in that leg. I would definitely see a vascular specialist if that's a problem. So you could get a good ultrasound and evaluation, and that should be able to sort out what the problem is.
Fantastic. And we have another question coming in from YouTube, and I'm not quite understanding. You might be getting it. From Bozo, I have PAD. Vascular wants to do 3 bypass, doing testing, stress, EKG, chest, CT, etc. I have been keto for 90 days now and can walk for 5 to 7 minutes until pain, rest 2 minutes, and repeat for a total of 30 minutes. And I have no pain while sleeping. I mean, this is a dream patient for me in terms of seeing progress with walking. And I always tell patients, walk, keep going, delay the procedure if you can, unless there's something acute, right? If you're making progress like that, that's incredible.
Yeah, I would agree.
love I love that you're so agreeable. We're just really big on walking. We have, I think I shared with you our walking program, and it's so just rewarding when you see people that are told that they need all of these procedures and you teach them how to walk effectively, and they're empowered. And when they start seeing those results and they're like, why did the doctor want to cut me open when I could just do this myself?
You
And
can,
it's
and you could add,
absolutely amazing.
Kim, you could actually add a couple other benefits to walking besides providing the collaterals and helping your PAD. It will help you live longer. It will decrease your risk of coronary disease, um, and probably at least a couple of other things will significantly improve and significantly improve your ability to handle glucose and your diabetic control. So you can add all of those to your benefits of walking.
So walk, 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 walk. And we do have, for those that are tuning in on YouTube, we have our global walking therapy researcher of the year from Glasgow, Scotland, who will be online on Wednesday morning, 8 a.m. Pacific time, 11 a.m. Eastern time, right here on YouTube. And he will be answering your questions on walking as therapy. So you don't want to miss that. We have another question about heredity, and I saw one coming in from Melissa as well. What are the greatest risk factors in getting PAD, and why does it skip some generations and affect others, even with the same risk factors? That's the $1 million question.
Well, I think, and to answer that and to look at that, you would need to, I think that's assuming that all of those variables are the same in each of those groups of people. So I think a lot of it may vary. I don't think it's an easy answer to that question.
I mean, they're basically saying, is it hereditary? And we see that in so many cases it is hereditary. And some people end up with not smoking, not having diabetes, and they end up with having PAD, even though they're not triggering it. But then other people don't. And it's really tough to know why, isn't it?
It is, and plus, so what you don't know is how those those different family members were treated. Does everybody have high cholesterol in the family, and did only some of them get treatment, or did some of them significantly change their diet that it actually affected their lipid levels? Or did they have other protective genes maybe that help them avoid the effects of PAD or coronary artery disease? So there's kind of a lot of variables.
I think we covered some of this earlier, but she wanted to ask the question directly. Catherine, I get concerned sometimes seeing articles on some docs doing too many procedures. What are the indications for a bypass if my thigh artery in particular is blocked?
Okay, so I'm assuming that she asked what are the indications for a bypass? So I usually will start endovascular if I think the patient has an appropriate indication, and that would be disabling lifestyle limiting claudication symptoms, despite optimizing all of your risk factors, or things like tissue loss, ulcers, things that don't heal, pain that you get even when you're laying down in your feet. Those would all be indications for treatment. Now, I usually will go endovascular first and then would reserve bypass later.
Yep. Okay, we have another question coming in actually from the UK. Another tough one here, but I think what she's looking for is probably the request maybe for a CT angiogram for confirmation. But, what do you do when your ABI test reads 1.48 and the GP and consultant said they're unable to detect a pulse in the leg, but because the ultrasound showed good blood flow, they're now refusing referral to a vascular or to have a radiographer, another radiographer actually read the ultrasound again. She doesn't know what to do. It's NHS, so it's tough for her to navigate. Is it still possible that she might have PAD, and what are the tests that she should request of the doctor to confirm either way?
So it is possible. And again, and in terms of how likely it is, I might want to find out, is she having symptoms? So for one thing, maybe they just didn't feel a pulse. But if she has no symptoms at all, my index of suspicion starts to go down a little bit. The ABI can be misleading. So that ABI is elevated, and it can be elevated for a variety of reasons. One of them is just if you have calcifications in the blood vessel, even if you don't have any blockages, those calcifications can artificially elevate that blood pressure reading and elevate your ankle-brachial index. So one test that you could ask for, which they may or may not have where you're living, is to get toe pressures, because toe pressures typically are not artificially elevated like the ankle-brachial index.
That's interesting. That's a really good point. And that's much less invasive than having to do a
And
CT
then
angiogram, much easier.
And then there would be one other is if you looked at the tibial vessels, which are the blood vessels below the femoral artery and the popliteal artery in the lower leg, if the ultrasound says that there is triphasic or biphasic flow in those blood vessels, then there's a pretty good chance that you do not have significant peripheral arterial disease.
We know that PAD causes reduced oxygen flow. Is oxygen therapy something that would help with PAD patients?
Well, the only situation that I could actually envision it helping would be someone who has a wound that's not healing. You've tried to optimize everything in terms of the blood flow, and then you put them in hyperbaric oxygen chambers, and sometimes that can achieve wound healing. But in terms of just generalized PAD, or would it help you with your walking, I don't think it would make any difference.
Fantastic. Thank you. Okay, we have just a few here. I know you're still at the office and probably have patients to see. Teresa, a lot of them are a little bit similar, but it's interesting. Can a stent actually be unblocked in the femoral artery? If yes, she doesn't understand with symptoms why her vascular surgeon would say, no, there's no point, as it will just block again, is what they said. So why do it? It's just going to block again. So that's what she wants to know. That's Teresa.
So it's hard to know because each one of these situations is different. But bottom line, if it's only happened once, I usually would try to go back in, unless perhaps that surgeon thinks that there are some underlying special factors they are in that particular blood vessel that they don't think they can open, and that it's futile to do further treatments on it. And I certainly have had limbs or blood vessels that I have treated and retreated, and at some point said, you know what, this just doesn't make sense anymore, and let's consider a bypass. I actually did that 3 weeks ago on a gentleman who's now walking 5 miles again.
Oh, that's amazing. That's fantastic.
Yeah, it's super cool.
Um, this is an interesting one, and you can answer it the way you like. How do you advise your patients on supplements? Do you advise your patients on supplements? And have you heard of the nicotinamide riboside as a supplement? But she just overall, Teresa's just mainly curious what your view is, because in our groups, supplements are the number one thing that everyone talks about. They're always looking for a different supplement that might help clear their arteries, melt the plaque, whatever it might be.
So I usually don't give very much advice about supplement. I am actually just starting my own journey about learning them and seeing what's good for me. So I think the way I would view supplements is, let's try to optimize everything else, and then you can kind of consider supplements. I don't think that there is any magic supplement out there that is going to eliminate the atherosclerotic disease process is involved in PAD.
Yeah, we have all kinds of, we have a functional medicine practitioner that comes on. She's a nurse practitioner as well that specializes in cardiovascular, that comes on every single Wednesday, that helps people. We discuss supplements, the ones that have clinical studies. We even have a vascular surgeon who has come on, and he prescribes Ceylon cinnamon capsules because he has seen evidence, and he shares the study with his patients, and he puts those patients that have type 2 diabetes on Ceylon cinnamon capsules. 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. He also prescribes, you're going to love this. He also prescribes a very specific olive oil from Amphora Nueva, amphoranueva.com/Marin, because it's the healthiest olive oil clinically proven by UCLA and UC Davis 3 years straight. So he tells all of his patients that they have to call this one number for Amphora Nueva and Marin and get this olive oil for them. And we have one cardiologist that actually prescribes chia seeds, and wants the patients to have a certain amount of chia seeds, ground chia seeds, every single day, because studies have shown that it reduces blood pressure and glucose. So it's very interesting, the different types of doctors that are out there, and what they tell their patients.
I think that I think if you, before you consider any supplement, just do a deep dive in the literature. They actually have some pretty neat sites that will actually they actually will provide a list of the studies done for those particular supplements and whether there's actually any data to suggest there's benefit.
Yep. And that's what we always look for. We always look for those studies that we can share with people. But we always tell people, make sure you do go back and talk to your dietitian, talk to your care team, and especially talk to your pharmacist to make sure there aren't any issues with the medications that you're taking. But Erin wants to know, what is the life expectancy for people with PAD? They go online and Dr. Google tells them that they have 5 years to live once they're diagnosed with PAD. So she wants to know, will we just deteriorate slowly or quickly? Is it reversible? Can we put it in remission? What are your thoughts?
So the answer to that is you can certainly slow the progression significantly. I don't know if I would actually go so far as to say that it's reversible, but you can get to the point where you don't have any symptoms and that you may never be affected by it.
Perfect. And there is still so much you can do to slow the progression. I mean, it's incredible with diet and exercise, and
I think
so
with
empowering.
lifestyle changes and risk factor modification can do wonders.
Yep. Okay, so just a couple of fun ones. It's the regular series that we have. One is, what are the 6 minutes that have mattered in your life or your career? When I was at Forbes magazine, I had a series called The 10 Minutes That Matter. It was a defining moment in your life or your career, a catalyst for change, a shift in your direction. We do the 6 minutes that matter because it's sponsored by Reflow Medical. And with their new scaffolding, the retractable scaffolding, they want to drive home the point that you need to leave the scaffolding up for 6 minutes. And they want doctors to be very patient. So 6 minutes
I've met with them. So I'm interested in if they get their FDA approval.
Yes, me too. So help us out. What were the 6 minutes that mattered in your life or in your career, a catalyst for change, a change, a truly defining moment for you?
One would probably be with my children. This would not be related. And there are several moments like that. Career-wise, it would probably be things that you wouldn't necessarily expect. And I won't give you the exact 6 minutes, but what I could say is that we have a remarkable ability and opportunity to really connect with our patients. So sometimes we're as important in their lives as their pastors and their family members, because oftentimes we may take care of, really life and limb for them, and we can get very, very close. And I would say some of the times when you've done a procedure and perhaps you saved a limb or you saved a life, and you can actually see it in their eyes that they know exactly what you did. It's a pretty deep connection, and I think that's something that has become more and more important to me, as opposed to, say, just doing the procedures, which is what initially drew me into vascular surgery.
That's amazing. And one final question for you. So I want you to share a case. It's a series called The Pulse, a case in which a very specific case, in which you learned a big lesson, good, bad, or indifferent, and that others could also learn from. This particular series is geared more towards physicians.
It was relatively early in my career, and it was a very big procedure that I did on a patient. And I think the one thing that I would have done differently was she had a complication after surgery that is a recognizable complication and often can be managed medically, or optimizing kind of their inpatient status, for lack of a better word. But in this case, she needed surgery, and I would have liked to have done surgery earlier. And I think that for surgeons, if you're thinking about going back to the OR, then you probably should do it.
Thank you, Dr. Skiller, and we really appreciate you, Dr. Sean Skiller, and he's in Ventura, California, Southern California. We really appreciate you being here, appreciate your time, and answering all of our burning questions.
Yeah, absolutely. It was super fun. Thank you.